All right, so thank you for the introduction and again for the program organizers for inviting my mentor and allowing me to give this presentation today. As mentioned by the moderators, the topic that we're going to discuss in our short time together today will really try to focus on exercise in the world of CFTR modulators and really the impact that these therapies have had on exercise testing or exercise capacity. So really to just briefly review and kind of get us started on this topic, we are all extremely very familiar with the clinical and research value of cardiopulmonary exercise testing. We know CPET is a valuable clinical tool that's often used to uncover pathology for dyspnea on exertion in various populations to give an almost oversimplified definition. Perhaps more importantly, exercise testing really provides this integrated physiological response, allowing researchers and clinicians to evaluate how the pulmonary, cardiovascular, and skeletal muscle systems interact and work together during these periods of increased physiological demand. In the world of CF, exercise testing is demonstrated to provide important prognostic value to the overall health of patients. And I know when I joined in this call, because I joined in a little bit earlier since it is bright and early over here, at least this right-hand figure was being discussed. But I know we're all very familiar with both of these hallmark studies on exercise and CF. But overall, these studies monitored patients over several years and just measured survival based on their aerobic fitness status based on % predicted VO2 peak. Both research groups observed that patients with greater aerobic fitness or exercise capacity had a lower rate of mortality or a greater survival probability compared to those with a medium or low exercise tolerance. And as mentioned earlier, this right figure really expanded on this hallmark study conducted by Nixon and colleagues 16 years ago by conducting this larger, longer term and multi-center study, which really just drove home the importance of exercise testing in CF. So the importance of monitoring exercise capacity in CF is not new to any of us here on this call, but really today I was given the task to try to highlight the importance of modulator therapies on exercise capacity in CF. And to do this, we're going to attempt to go through that in the next several slides by going through a few studies on the different modulators and exercise that have been published recently. So our first available modulator, Kalydeco, was approved in 2012 for patients with a G551D mutation. This therapy option has had a great positive effect on a number of patients with CF, and was really the first to be investigated in relation to exercise capacity. This group from Australia investigated if ivacaftor improved exercise capacity in a similar time frame as it does lung function and body weight. 20 male and female participants with CF underwent a double-blind, placebo-controlled 28-day crossover study. In line with previous findings, Edgeworth and colleagues observed significant improvements in FEV1, weight gain, but there were no improvements within 28 days of treatment with ivacaftor in VO2 max. However, these patients did have an increase in their exertion duration. And this was also accompanied by an increase in habitual exercise as measured by CFTRs in this study. This lack of improvement in VO2 max with ivacaftor, despite these improvements in not only ventilatory parameters and exercise duration, suggests that these ventilatory parameters that are increased by ivacaftor are not the sole driver in changes in exercise capacity. Additionally, the study will only assess VO2 peak after 28 days of treatment, and it very well could have required a longer duration of treatment to observe these improvements. Nonetheless, the authors recommended that future studies start to include CPET in addition to lung function to fully understand and assess the physiological response to therapeutic interventions. And this study really set the groundwork for assessing modulator therapies on exercise capacity. And even though we have newer generations of modulators, there are still studies ongoing and being published expanding on these previous findings on ivacaftor alone in exercise capacity. This was an observational study published in just 2020 that evaluated the long-term effects of ivacaftor on non-pulmonary outcomes. Improvements in BMI and pulmonary function were observed as previously stated. Interestingly, there was a significant decline in % predicted VO2 peak in this study, whereas there was no change in the peak work rate in these patients. The authors kind of suggest that this decline that was observed in VO2 peak is likely due to a lower work of breathing, which was supported by their finding of almost a 50% reduction in static hyperinflation after the treatment of ivacaftor. Also in this study, there were recruitment issues where only 7 individuals were actually included in this final analysis. And due to time today, really, these are the only 2 studies that I'm going to present that investigate the impact of ivacaftor on exercise. And as you can see, the results are not quite conclusive on how ivacaftor alone may be impacting VO2 peak. But that leads us to our next generation modulator, the dual combination of lumacaftor ivacaftor, or also known as Orkambi. This was approved back in 2015 for people homozygous for the F508del mutation, which now offered a treatment to help a larger number of patients than ivacaftor alone. This is also where the majority of what little information we have on modulators on exercise actually stems from. So a case report study published investigating Orkambi and exercise in early 2019 followed 3 adult patients pre and post 2 years of initiation of lumacaftor ivacaftor. And for the sake of time and space, I'm only presenting the data from one of the patients that was presented in the study. The data was similar across all 3 patients, and the absolute data for the other 2 are presented in the lower right-hand corner. But symptom-limited incremental CPET was performed, and presented on the slide is the power in watts at each incremental stage along the x-axis, with percent predicted VO2 peak presented on the y-axis. The authors also present the pre-data in blue, so the pre-treatment data, and then the post-exercise data following treatment with lumacaftor ivacaftor for 2 years. And presenting these on the same figure allow us to really appreciate the increase in oxygen consumption at each incremental stage following treatment with lumacaftor ivacaftor for 12 months. Importantly, oxygen consumed at an anaerobic threshold, as well as peak exercise, were also increased in all 3 participants. There was also a multi-sensor armband used to monitor daily physical activity, which was observed to be increased in these 3 patients. Overall, the study concluded that following 2 years of lumacaftor ivacaftor initiation, there were substantial improvements in oxygen uptake values during CPET in these 3 subjects, but more information or studies including larger sample sizes were required. So in fact, expanding a bit on these previous findings, Work and colleagues sought to observe which exercise parameters would be the most sensitive to change upon treatment with lumacaftor ivacaftor in patients with severe lung disease, as defined by a FEV1 of less than 40%. 6-minute walk test, spirometry, gas transfer, and nitrogen multiple breath washouts were assessed in 10 adults at baseline, 4, 12, 24, and 52 weeks. And here I present the major takeaway, the major exercise takeaway anyway from the study, where the distance in meters is presented on the x-axis and as either the change from baseline or the absolute distance walked during the 6-minute walk test. And hopefully you can appreciate the significant increase in the distance walk that occurred as early as 4 weeks following the start of lumacaftor ivacaftor. This improvement in exercise tolerance peaked at 24 weeks, but was maintained out to 52 weeks. These 10 patients also only had modest improvements in their lung function, but this was really one of the first studies to kind of evaluate and show the improvements in exercise intolerance with lumacaftor ivacaftor. Here's another preliminary study where authors evaluate the short-term changes in exercise performance and ventilatory responses in 7 adults with CF. Submaximal exercise tests were performed at least 1 week prior to starting lumacaftor ivacaftor, and then again 1 month post initiation of the treatment. Interestingly, 6 of the 7 participants increased their endurance time, but this did not achieve statistical significance, which was likely driven by 1 participant, which the authors reported had a decline of 8.1 minutes in their exercise duration. This participant also experienced an pulmonary exacerbation 2 weeks prior, but were still included in the study. Otherwise, there was no significant change in the Borg dyspnea rating during exercise, and there was also no significant change in leg discomfort during exercise. However, interestingly, the authors talk about how 4 out of 7 participants that experienced a decrease in leg discomfort This reduction in leg discomfort was significantly correlated with the increase in the endurance time, suggesting that potentially lumacaftor ivacaftor is having peripheral effects that may need longer time or duration on treatment to observe changes. One of the more recent investigations on lumacaftor ivacaftor and exercise was a 24-week randomized parallel placebo-controlled design, in which data was collected from 13 clinical sites. VO2 max was measured at baseline, 12 weeks, as well as 24 weeks. And the primary outcome that the authors evaluated was the relative percent change from baseline in VO2 max following treatment with placebo or lumacaftor ivacaftor. Overall, the mean difference from baseline at 24 weeks for placebo versus lumacaftor ivacaftor was minus 3.2%. This suggests that lumacaftor ivacaftor did not improve or slow the decline in VO2 max in these subjects within 24 weeks compared to placebo. However, the authors present a number of convincing reasons as to why improvements may not have been observed in this data set. To start, the authors address that there may be procedure-related limitations, such as lack of a standard equipment or calibrations of the CPET equipment across the different clinical sites. There was also an inclusion of younger participants whose measurements may not have been as robust, because we all know that exercise testing in children is definitely more difficult. And simply the effects of treatment on exercise tolerance may have been overestimated. But really, the authors included every CPET test completed during the study, during the entire study period in the final analysis. So submaximal tests may have been included in this final analysis, but unfortunately, there was no way to really determine the effects of these submaximal tests on the test inclusions in the results. Finally, the participants really may have been relatively exercise intolerant to start with, creating potentially a selection bias and making it difficult to observe improvements in exercise capacity. The groups are also divided based off of percent predicted FEV1, as well as age and sex, and not divided based on their exercise tolerance, which could have also played a role, leading into how baseline fitness status was not controlled for in the study. And additionally, no protocol exercise regimen was included or enforced during the study. They were reminded of the recommended exercise recommendations for patients with CF, but they didn't have to participate in it. Therefore, that sedentary lifestyle that many patients participated in during the study may have impacted that metabolic response from occurring. And last but not least, we have our newest triple modulator therapy, which we call here in the US Trikafta. This combination therapy was most recently approved in 2019 for people with at least one mutation of the F50del mutation, which now includes or provides a treatment option for up to 90% of people with CF. And if we take a look at one of the phase 3 clinical trial results, the primary endpoint is percent predicted FEV1 with remarkable improvements in this primary outcome. But if we scan the secondary outcome endpoints, again, exercise capacity and exercise laboratory parameters are not evaluated, not considered. So once again, despite this important predictor of mortality in CF, we're not investigating it as or understanding how the physiological effects of these treatments are impacting potentially exercise. So really, in the short time that we kind of had together today, I've tried to cover and highlight as much as I could about what we know regarding these impacted modulator therapies on exercise. But I do want to note that there are other small studies and case reports published in the literature that I didn't have necessarily time to sit down and discuss today. Regardless, the data on this topic is severely limited. And despite the prognostic value of exercise capacity in CF, clinical trials are not investigating the outcome for these modulators on exercise. And what information we do have is a little bit contradictory or inconclusive based on the small sample size and different exercise parameters. And really, these early studies focus on these earlier generations of therapies. So we don't really know the impact this newest triple modulator may have on exercise capacity. It's definitely a new line of research to go down. And we also really didn't get it into it today, but it did cross my mind and has kind of been crossing my mind as I've been listening into other presentations today, but there may be an impact of habitual physical activity or participation in more exercise programs in relation to modulator therapies. As I mentioned, some of these studies today that I presented, as well as others online, kind of attempted to capture how these therapies are affecting overall physical activity by using different activity monitors and actigraphs. And there is a slight improvement in physical activity in these patients. So that definitely could be an avenue where we could improve exercise capacity by improving daily habitual physical activity. But overall, the impact of modulators on exercise and exercise capacity are still being eluded. So with that being said, I just want to take a quick moment and thank all of our participants with CF. Without them continuing to participate in all of our research, we definitely wouldn't be able to understand the physiological consequences of these modulator therapies on exercise and overall health. And I definitely want to make sure I thank all my team members here at the LISP. It takes a team to conduct great research, and I'm definitely very lucky to work with not only dedicated colleagues, but dedicated patients. So thank you all for listening, and I am open for discussion.